lands of many of our First Nations. And today I'm coming to you from the land of the Coast Salish people in Seattle. Um, Cascadia has a number of committees, one of which is dedicated to life sciences. Our co-chairs for the Life Sciences Committee are Dr. Lesley Esford, a life sciences expert, entrepreneur, former executive director of life sciences in British Columbia, and Dr. David Grossman, National Senior Medical Director for Community Health Kaiser Permanente. And David has been loaned to everything COVID since last March, and he and I have worked together constantly since. And together, these two, along with Cheryl in British Columbia and Kaylin here in Seattle, put together a terrific program with experts that are absolutely top. We are very fortunate to live in the Pacific Northwest and have these folks available with us today. If you're not familiar with the Cascadia Corridor, it's an initiative to really join us together in collaboration within the Cascadia mega region, which connects us from Portland to Seattle to Vancouver. And mega regions, there are 11 in the United States, are really committed around economics. We're quite different because we share something I think is equally important, and that is values and culture in our mega region. The COVID-19 pandemic, of course, has really challenged this collaborative initiative that we've undertaken, having our borders have to be closed. But while we remain physically, I'm sorry, while we're getting feedback, my apologies, I don't know why. While we remain physically distant, we are still continuing to collaborate every single day. In fact, sometimes I think we're even closer. And we do not let the divide of the border stop us in any way. Washington, as you probably are aware, was unfortunately known for where the first case and the first death from COVID-19 happened. And we began from that moment forward to work as a partnership, being at the forefront of combating COVID. Over the past year, our region has been really a leader on the vaccine research, and you're going to hear about that today. The development of best practices for testing and creating partnerships, which has been recognized, at least in our country nationally, as the way in which you attack and win at COVID. Washington State has had a robust public health response to the pandemic, focusing on really science, data, and experts, and really not letting anything else interfere, and communicating with the people across our state, across our region, and in partnership with Greg. Our private sector businesses have stepped up in ways that are unprecedented to address the crisis. For example, in the early days of the pandemic, when we were in dire need of PPE, they rallied together, went globally, and brought in over 5 million pieces of PPE for particularly our healthcare workers and our first responders in Washington State. They have stood up when we were in a blood supply crisis, a food supply crisis, and they have raised over $100 million in philanthropic giving to those who are really struggling to make ends meet during these challenging times. And over the last couple of weeks, we have come together in an unprecedented way, trying to figure out how we deliver vaccinations equitably, efficiently, effectively. And so we've stood up a command center at the state. Our governor has done so. That command center is now supported by a public-private partnership. We figured out that if you can deliver 1 million cups of coffee a day efficiently and effectively with satisfied customers, well, then we can get the shots in arms in Washington State for 5.4 million until we are able to vaccinate our children for a total of 10.8 million. We are grateful for the strong leadership that we've had at the state level. Our public sector has stood up and doing a fabulous job, so too at the local level. Our U.S. government has not been a really supportive partner over the past. We believe right now that we do have a partner now, that it's based on science and data, and that together we really can be optimistic about our future. And throughout all of this, my partner always has been Greg, where we've compared notes, we've asked what we can do together, we've asked what our respective employers can do to be of help to the public sector. The pandemic continues on, unfortunately, and is still quite dangerous. The next 6 months are critical to us. We have to make sure we're getting shots in arms. We don't have the supply we need or want right now, but I'm optimistic going forward. And of course, we're all concerned about mutations, and we'll talk about that in just a minute. It certainly hasn't been an easy road for any of us, and for all of the people of British Columbia and Washington State, but together we have learned a lot. We have made immense progress, and while we can see light at the end of the tunnel, the fact of the matter is we cannot let our guard down. There is a lot to be done, and we need to learn lessons, which we intend to do, like never letting the border be closed again, because we put in place precautionary safety measures that would allow us not to have to do that. Sharing these learning experiences and information, we want to be prepared not just to win today with this pandemic, but any other that might have to be confronted in the future. So today we share that partnership, and I can't tell you how delighted we are to have this panel of experts in both panel 1 and panel 2, and the shared experience and expertise across our border. So with that, I'm going to hand it over to my colleague, Greg Diabnon, who serves as the co-chair of the Cascadia Innovation Corridor and the president and CEO of the Business Council of British Columbia. Greg has been a fantastic partner with Challenge Seattle and his team, Cheryl and the rest of the folks there, and the entire Cascadia region has been very fortunate to have the leadership of Greg and his team throughout this process. I couldn't be more grateful for his leadership. With that, Greg.
Well, thanks so much, Governor Gregoire, and good morning, everyone. Thank you for being here today on a series of discussions that I know I've been looking forward to for some time. Today's lineup of insightful global experts, innovators, and leaders in the region's life sciences sector are individually and collectively, literally saving lives in the global fight against COVID-19, as you're going to hear today. But equally important is that they represent potential, the potential to create and grow a dominant global center for health and life sciences, particularly precision medicine, biotech, and as Chris said, data-driven science that creates solutions to life-threatening and chronic diseases in oncology, heart and lung, brain health, and other viral threats that combined are going to make the people of the Pacific Northwest and the world healthier and safer. As we get underway, as Chris acknowledged, I want to acknowledge that I'm at the Business Council offices, and we are on the traditional lands of the Coast Salish people as well, specifically the Squamish, Musqueam, and Tsleil-Waututh nations. As Governor Gregoire noted, the Cascadia Innovation Corridor's purpose is to increase cross-border collaboration and to build our shared values and complementary strengths in technology, life sciences, talent, transportation, infrastructure, climate action, research, and post-secondary education. It's a big, long list, but it really is a testament to the quality and the talent and the companies and public sector support that's resident here in the Pacific Northwest. As Chris said, we also share the same sense of humor. When working together, Cascadia is more than the sum of our parts. It's through these collaborations that the Cascadia Corridor has the potential to be a mega region, not just of economy, but also sustainability, advancing solutions, ideas to address some of the world's greatest challenges and continue to have a high quality of life here at home. So speaking of world-class impact that's helping people be healthier personally, economically, as Chris did to me very graciously, I just want to take a moment to thank Governor Gregoire for her leadership in Washington State. She very modestly talked about the role that the private sector and public sector through the governor's office is taking to make sure that people get shots in arms. But Governor Gregoire's influence and coordination is well beyond making sure that Washingtonians are safe. She's been doing that collectively as the co-chair of Cascadia Innovation Corridor, but specifically as the CEO of Challenge Seattle, really improving the quality of life for people in Washington State and the Pacific Northwest. So Chris, just thanks so much for all you're doing for the people of Greater Seattle and Washington, but also for British Columbia. Chris, for those of you that have known her for a long time, it's not surprising. She was one of the first people to call me when the first identified case in Washington State of COVID-19 occurred, and she warned me that we better get ready. And not surprisingly, the virus showed up in British Columbia shortly thereafter. And so our guidance and insights early days were instrumental in our work at BC and among the private sector, working with government at speed to make sure we kept people healthy and kept the economy moving and open in a safe way. So for example, in 10 days, in part because of Chris's advice, we were able to marshal some resources from the private sector working with government to build the first digital and only PPE hub in Canada to support healthcare sector workers with the PPE they need. And it mounted to tens of millions of pieces of products. The digital supercluster and others took a leadership role in making sure that hospitals functioned and frontline workers remained safe. And I can say that our partnership personally and our collaboration over the years is just another example of how when this region comes together and people connect, we can really make a difference. Whether it's exploring, as I said, how to source PPE, the impact of public health measures on the workplace, how businesses can support the vaccine rollout, or our relationship and cross-border collaborations among people and companies and governments in the corridor are important. And despite the closure of the border, we've only been able to strengthen those relationships and opportunity in the last year. So in some respects, British Columbia has managed relatively well thanks to, again, data, science, and clarity, our ability to manage transmission in this province, both in the Canadian context and the North American context. But despite that, it's been a difficult year of loss and uncertainty for families in British Columbia, as it has been throughout the world and in Washington State. To date in BC, just to give you some data, we've had nearly 68,000 confirmed cases and over 1,200 deaths in a population of 5.1 million people. And more recently, we've had evidence in the last week of 18 cases of the UK and South African variants among our population, particularly in the Lower Mainland of Vancouver. And in the span of our experience with COVID, we didn't enter into a full economic shutdown of businesses, particularly small businesses. But despite that, those small consumer-facing industries, such as retail, hospitality, and tourism-dependent operations, have been devastated, and it's cost people lives, their mental health, and also their job. By way of example, BC, which is tourism-dependent, went from 6.3 million visitors from April to October of last year. We went from 6.3 million visitors from April to October of 2019 to just 207,000 last year. That's a 97% loss of people coming to enjoy our province, and it has profound implications economically. So how we safely open the border and how we resume travel is crucial not only to business and the economy and the people that depend on those sectors, but it's vital to enable the collaborations and increasingly foster relationships that we're going to need to both save lives, but also to ensure that people's mental health and economic health is vibrant and the opportunities are going to present themselves post-COVID. So despite the lack in BC, we're almost back to a near full employment in our province. There's a lot of people that are out of work, and particularly younger workers, women, and those of lower incomes that are vulnerable in this kind of an economic circumstance. So our team of economists, to give you a sense of some of the backdrop of impact, we've had the biggest economic downturn in a century of about 6% in 2020 with an expected 4.1% recovery, which will get us about halfway there. We're expecting that our economy will get back on track by the end of 2022. So there's lots of work left to do both on our health, but also on our economy. And like other parts of the world, we appear to be on a downward trend on our second wave. However, with the emergence of those new variants I mentioned earlier, we're facing additional uncertainty, increased urgency to expand testing, tracking, tracing, and obviously accelerate our vaccine distribution. And like our colleagues in Washington State, we have a lot of work to do on our personal health and economic track, as I said. So specifically, while Canada has faced supply issues, particularly with the Pfizer and Moderna vaccines, we are preparing right now with the private sector and public sector to ramp up distribution as more product becomes available in March. So as of yesterday in British Columbia, we'd administered 134,000 doses of the vaccine, about 2.6% of the population, plus another 4,500 of second doses. So we're trailing behind Washington and the United States, which are nearly at 7% of its population immunized as of yesterday. And if we reach the province's goal of having all 4 million eligible British Columbians who want a vaccine get both doses by the fall, we're going to need to ramp up that administration of the vaccine up to 112,000 per week. So in other words, cumulatively in the last 2 months, we've done 134,000. We're going to have to repeat that week after week through to the end of September. So with the leadership of Governor Gregoire, we know that Washington State business community has stepped up to help, as she alluded to earlier, and we're planning to do the same thing and have more meetings to affect change on distribution that will be efficient to help save lives going forward. And in the context of that, as we try to move back to normalcy, there is a light at the end of the tunnel, and opportunity thanks to some of the work of the researchers and experts you're going to hear on our panels this morning. Not only will this benefit our health outcomes locally, but as I alluded to earlier, we can become a global center for life sciences that becomes an economic engine that is going to support our recovery in the future. So I want to thank, as Chris did, our Cascadia Life Sciences Subcommittee co-chairs, Dr. David Grossman, as you heard, the National Senior Medical Director for Community Health at Kaiser Permanente in Seattle, and Dr. Lesley Esford, a well-known life sciences expert and entrepreneur in British Columbia, and for the work that they have done collectively in pulling together today's forum. Before I turn it over to Dr. Esford, I want to take a moment just to remind everyone, if you can, to please have your cameras off and put your mics on mute. It just helps with the background noise and the bandwidth and quality of the presentations. So during the panel discussions, please pose your questions in the meeting chat. You can find that icon up on the top right of your screen, and they'll be put into the panelists for thorough discussion as time permits. So finally, we're recording this session, and it will be made available in the coming days on our website at connectcascadia.com. That's connectcascadia.com. So it's now my pleasure to introduce my friend, Dr. Lesley Esford. Lesley is a BC-based life sciences expert and entrepreneur, serving on several boards in the private sector and public sector, and in an advisory capacity to a number of life sciences companies. She has her Ph.D. in microbiology and immunology, and was talking to me last week about her focus on virology as well. So she comes into today's conversation well educated and well equipped. She gained these degrees in her Ph.D. from UBC and previously served as the president of Life Sciences BC. Lesley, over to you. We might have you on mute, Lesley.
Thank you, Greg. What I'd like to do first is just to share a little bit about the work that we've been doing on the Cascadia Health Sciences Committee. Like both Governor Gregoire and Greg have mentioned, the life sciences sector has the potential to be stronger together and globally competitive. There are so many strengths in the Northwest, including the academic and research institutes, the health systems, companies, and talent. And certainly COVID-19 has actually highlighted the expertise and capabilities of the region. If we consider only the companies that are located in Vancouver and Seattle, both are clusters in themselves, but together they represent critical mass. There are some areas of strength that are noticed across the Northwest: data, machine learning, AI, quantum computing, drug development, in particular antibody drug development, areas of strength in oncology, and precision medicine. Those of us that are involved saw the potential and came up with some action items, and we call them the 3 A's, where we wanted to make a difference. The first, we realized very early on that we didn't know each other well. So the first A is awareness, that leads to regional networks and collaborations. And we've seen is that as we strengthen those connections, we're going to be a stronger ecosystem. The second A is actionable data that leads to curing diseases and other health breakthroughs. We've certainly seen the importance of data in COVID, in our response to COVID-19, and it will continue for us to inform the next pandemic. The third A is accelerated collaboration to lead to better outcomes for regional public health responses, obviously including COVID, but prior to COVID, we were looking at a regional response to mental health and addiction. But today we brought together an amazing lineup of panelists to talk about our response to COVID-19. No other time in our life have we experienced a health, an economic, and social crisis at the same time. We've seen a public health response as well as a response by academics and industry to lead to solutions. And we put together two panels, one to talk about, the first panel to talk about diagnostics and testing, and the second panel to talk about vaccines and treatments. The objectives of today's webinar is really to bring awareness of the outstanding work that is being done in the region in response to the pandemic. The second is to talk about collaborations. We've seen an accelerated sharing of knowledge that has led to an accelerated development of products and services that would not be possible with multiple types of partnerships, public-private partnerships. We've seen companies come together and share their resources in order to move things along much faster. And the panelists on both panels will be talking about how this was possible to accelerate the development of diagnostics, therapies, and treatment and vaccines. And the third is the sharing of perspective and best practices, so we are better prepared for the next pandemic. So at this point, I'd like to turn it over to my co-chair, Dr. David Grossman, a senior investigator and a pediatrician at Kaiser Permanente, and the senior medical director for Washington Permanente Medical Group. I am fortunate and very pleased to have him as my co-chair. And so over to you, David.
Thank you, Lesley. Good morning, everyone, and welcome, and thanks so much for joining us today. This is we have a set of two panels today with a dynamo lineup of experts and scientists who I think will, from which I know we will learn a great deal. The first panel is going to be focused on the SARS-CoV-2 testing, development, implementation, and where we've been as well as where we'll be going into the future, relying on these experts' opinions and knowledge about from the positions that they stand. This first panel, I'm really pleased to introduce, consists of three people. The first is Emily Turner. Emily is a senior program officer at the Bill and Melinda Gates Foundation here in Seattle, and also is with the Innovative Technology Solutions teams. Emily brings particularly focused expertise on SARS-CoV-2 because she's a task force lead for COVID-19 diagnostics. And I've had the pleasure of working with Emily quite a bit on some of the Washington focus with testing, as well as, of course, much of their work that they've been doing, which is globally focused. Our second panelist is Dr. Charissa Fotinos. Charissa is a family physician who is the Deputy Chief Medical Officer for the Washington State Healthcare Authority, where she heads up the areas of substance abuse and mental health. Charissa has been for the past year, has been loaned from the Healthcare Authority to our Washington State Department of Health, where she's headed up a task force focus on testing and dissemination of testing and testing strategies for Washington state government and local health jurisdictions. Charissa has a great deal of experience in understanding how this has played out on the front lines, and will share that with us. And then finally, we're very pleased to have Sue M.P.H, who is the CEO of Canada's Digital Technology Supercluster, and also is serving as co-chair of Canada's COVID-19 Testing and Screening Expert Advisory Panel. Sue is a renowned expert in biotech in the sector, and she chairs 3 boards and is very involved in a variety of in a variety of scenes related to COVID. So it's my pleasure to welcome these 3, and hoping that all 3 can open their screens. I also want to mention that in the chat, you will see links to the speaker bio information. So if you'd like to know more about the speakers, by all means, please go ahead and click on that link, and you'll learn more. So if I could ask Sue, Emily, and Charissa, if you can open up your screens for me, that would be terrific. Great.
You can see me, Dave.
Yep, and audio's all on. Perfect. Thanks so much. So I'm wondering maybe what we can do is start a little bit and talk about your views, each of you, make some opening remarks if that's okay, and reflect a little bit about some of the testing strategies from your perspective that you believe have been effective through this pandemic so far. What have we learned about what's worked best? And then maybe at the same time, contrast a little bit about how the jurisdiction's approach to testing have impacted your ability or our ability or inability to actually manage the virus. So I'll go around here and maybe I'll start in the opposite order I introduced folks, and maybe we'll start with British Columbia and Canada. Sue, would you mind opening?
Sure, thanks, David, and thank you to Chris and to Greg for putting this together. The Cascadia Corridor has been a favorite of mine for years because we've known for a long time that borders in many ways are artificial, and COVID-19 has certainly shown that to us, that it knows no borders despite what we try and put up in front of it. So I'm going to provide a few comments in the context of both my role as the Supercluster CEO and my role as co-chair of Canada's COVID-19 testing and screening expert panel. And I'll start with that first. So in the fall of last year, the Federal Minister of Health in Canada established a testing and screening expert advisory panel with the objective of providing evidence-based, data-based, informed guidance for provinces and the federal government respecting testing and screening. And I'll just pause here and just note that in Canada, health and the delivery of health services is a divided or a split jurisdiction, with our federal government having certain jurisdiction in terms of procurements and major policies and funding, and deployment of health services rests with our provinces. And even within the provinces, there can be additional divisions of jurisdictions through health authorities. So it's a little bit of a patchwork, and that's been both positive and negative in COVID. So from our testing panel's perspective, we looked at the 4 parts of the public health response to COVID. So find, test, trace, isolate, and support. And we know that's important because up to 40% of people carrying the virus may not have symptoms, and so they can infect others without even knowing that they have the virus themselves. And we also know right now that many countries are focused on vaccines, and that's good. But we're in uncharted territory right now with vaccines. We don't know the efficacy. Obviously, many countries, including ours, have supply chain issues. I know the next panel will talk about this. And so testing remains crucial. And so, I may be vaccinated, but I might still carry the virus and shed it and infect others. So testing remains critical. And our panel has issued 1 report in January with an overarching set of recommendations around testing and screening. And we will be issuing 2 more in the next 3 weeks, focused on specific elements of society. So what's worked well? First of all, and without equivocation, the thing that has worked the best in our country is the commitment of our frontline health professionals. It's beyond imagination. Across the country, across disciplines, across demographics, the dedication of that group has been phenomenal. Secondly, what's worked well is, in some contexts, rapid tests. Government of Canada, as of February, had procured 17 million rapid tests and deployed them to the provinces. And just to put that into context, population of Canada is about 38 million. The deployment of those tests goes into the next category. This third thing that's gone quite well is that provinces are being brought together in forums to have discussions. And so that's a convening exercise that's gone well. And the last thing that I'll talk about that's gone well is the willingness of the business community to help. And Greg has referenced this. And in our supercluster context, I can tell you a story about who we are and what we do. Let's just say we're a novel approach to innovation. We launched a COVID program quickly at the beginning of March, seeking consortia to provide submissions to develop technologies to address COVID issues. In about 6 weeks, we got 400 qualifying submissions with a $1.4 billion project value for a fund that was about $60 million. The good news there is we were able to select the very best. And I can talk a little bit more about that in a moment, but the one that I'll reference is the one that Greg referenced, which is the supply hub, which literally over the space of a weekend, we put together a platform to allow the sharing of information about PPE availability with customers that needed it. And I'll get you the updated today number in terms of how many units have been transmitted, but it starts with a B. What's not worked well? Very quickly, letting perfection be the enemy of the good. Waiting until we fully understand something before we test it or try it. That has been a significant problem. Poor leveraging and deployment of technologies, especially in things like tracking and tracing apps, and having each jurisdiction develop its own bespoke approach to tracking and tracing has not worked. Failure to engage and activate the private sector in technology, in deployment of tests, in sharing information, and so that's not what's not worked well at all. I'll save my comments on looking to the future for a later part of the discussion, David, because I think I'm over time. Thanks.
Thank you, Sue. That was extremely interesting. I also want to mention for the audience that as you begin to think of questions, the place to put those is in the chat. And I think many of you are familiar with Teams. There's a little chat bubble at the very top of the screen. Feel free to put those questions in the chat, and we have people that will be watching those questions and bringing those forward to us. Next, I'd like to turn to Sharisa, Dr. Fotinos. If you could tell us a little bit about your perspectives as a state leader watching this unfold, and how you've been able to both watch the state ability to respond as well as private sector. Tell us a little bit about what you think has gone well so far, and where have you felt like we've had some problems?
Great. Thank you, David. Thank you for the opportunity to share some of my thoughts this morning. I think that there have been a number of things that have gone well, and a number of things that have sort of challenged our ability to have a consistent response that really, at the heart, provides the best information that we could have to combat the SARS-CoV-2 virus. I think that initially we were hampered by the fact that we did not have enough supplies to perform testing, nor enough PPE to support providers doing that. And one of the things that set up, which was unfortunate, is primary care providers really didn't have access to testing. They didn't have access to testing or PPE. And so as we were able to, with the help of our federal partners, get more testing supplies, it was a bit of a challenge to get the primary care and the community clinics to step up and test. They'd been dealing with folks who were sick without testing and said, it doesn't help me if they have COVID, I'm going to treat them the same way. So part of our challenge was in that initial scarcity of supplies, really sort of changing the attitude for testing up front. One of the things that clearly has helped that is the introduction of rapid antigen tests, and that's a whole other discussion about their utility, but I think having those be more available in places that weren't able to test before, correctional facilities, mental health facilities, all the community health centers, I think that really helped open up testing. I think one of the particular challenges of Washington, and I think it's similar to what Sue described, is that, we had our federal partnerships, which I will say for the testing piece, when we were able to get regular supplies of swabs and transport media for an extended period of time, and those were reliable. Once the quality issues were straightened out, that was very helpful for us to be able to provide support to hospitals, clinics, and local health response. Similarly, the purchase and distribution of the rapid antigen tests for the state in a steady stream over a period of months was also very helpful to have people be able to respond. One of the challenges, however, is that we have 39 local health jurisdictions. And in that, some are controlled in a health focus, others are controlled by their county government. And so that creates a home rule situation where each county can kind of decide, or jurisdiction decides, how they want to manage things. So as Sue referenced, we had 39 different ways in which to approach testing, how to interpret testing, and how to respond to that. So I think that has been and remains a challenge. I think that people are tired enough in the response that they're a little bit more willing to say, just tell us what to do and we'll go forward. So I think that tension between wanting to manage your own community versus sort of listening to either state or national guidelines was a bit problematic. And I think I'll probably just end, I think the lack of sort of national support for both a strategy and a consistent way in which to know that we can have supplies and distribute them effectively to where they need to go, because so much time has been spent on tracking down vendors initially and figuring out who you can buy from, and because that was part of it, people could not expect to get regular supply chains for even their PCR machines. I mean, we still struggle with shortages. So I think it's been a mixed bag. And I will finally say what's worked well is the absolute dedication of the folks in public health. I am not a Department of Health employee, but I've worked with them for the last year, and their persistence and passion and doggedness is impressive. And I think in large part, their continued efforts, both at the state and local level, have been what's helped us get to where we are.
Thank you, Sharisa. As a public servant, I just want to express my thanks and gratitude for all that you've done for Washington, as well as other public servants. It's been absolutely vital. Thank you. Emily, you, in your role, you're really at ground zero at the Gates Foundation, having to think about how to test the world, let alone BC and Washington. I'm wondering if you could just shed some thoughts, your perspective, and maybe draw on some of your international experience in watching how this is unfolded internationally with, vis-a-vis our region, and what you think has gone well, where you think there's needs for improvement.
Sure. Thanks very much, David. And thanks both to the organizers and the large group of attendees for pulling together this forum. I'm very excited to be among this group. I mean, I think that's an excellent point, David. And I think what has been the most remarkable thing is that a lot of the issues we've been dealing with for decades in global health really do translate now in this time of COVID, where we just have a sort of overwhelming demand and a constant supply constraint for diagnostics, therapeutics, access to clinical medicine. And it turns out that a lot of these issues of global health have some relevance now, for BC and Washington State, or indeed the entire United States. I think in terms of the things that have gone well, I think this is true globally, but it's particularly true in Washington State and BC, has been the immediate activation of committed energy by core public health, clinical medicine, academic, private and public, healthcare partners to respond, in quite a vacuum of knowledge and clear need. I think if we turn to Washington State, it was remarkable how quickly entities like the University of Washington stood up sort of proactive testing approaches to try to get the kind of baseline response available, really kind of turning on a dime. I think the same was true. We had very good partners at Evergreen Health trying to look for, innovative new ways to address supply chain and PPE constraints associated with the administration of diagnostic testing. And I think that kind of sort of selfless energy and dedication, as others have referred to, really has been true both in the sort of Cascadia Corridor, but certainly across the globe, where people are working in very difficult circumstances and just, pushing and pushing to make things better. But I think, the thing that I would highlight as the sad reality, and this is true for COVID and certainly true for global health, is the equity gap. I think it's true for diagnostics, it's true for access to clinical care, now access to vaccines. And we see that traditionally disadvantaged populations continue to be disadvantaged in their ability to access these emerging new modalities. So at the foundation, when we think about both the implementation and delivery of a new diagnostics technology, or even in the investment of an upfront innovative new technology, we really do try to focus on addressing that equity gap. How can we get tests to the untested? How do we reach people who either cannot or will not access high complexity testing sites? I'm happy to go into more details, but when we think about, test formats, manufacturing volumes, price points that are suitable for low and middle income countries, which are sort of our traditional partner jurisdictions, it turns out that those approaches are quite relevant for even high income countries who are now considering what we would call maybe community access testing So that can be something done in a kiosk or with a mobile healthcare worker in a van or eventually even at home. And so some of those core technology and implementation lessons do in fact translate back into the United States and Canada. I'm happy to talk more in the discussion.
So global to local, so to speak.
Yeah, I guess so.
Thank you. Well, each of you talked about the issue and touched on the issue. And again, I want to put a call out for questions from the audience because we'll be moving into Q&A with your questions. So please, I've not seen any come through so far, so hopefully we'll have some coming soon. But I wanted to raise this question that actually Sue first raised, which is around antigen testing. Antigen testing, Sue, I think you mentioned the good news was you got 17 million kits, and then you alluded to say maybe some downside on the antigen side. But the antigen has been an issue of hot debate. I know Washington State has received a lot of antigen tests for on assistance from the federal government. Each of you I know understands the antigen issue. I think PCR has really gotten a strong foothold in all of our communities, clearly. And certainly the focus has been to move PCR into in state or in province so that we can get as rapid a turnaround time as we can to effectively take those next steps that Sue talked about around isolation and quarantine, which is ultimately the end game for testing. But let's just talk for a second about antigen testing and where we're at with that and what your views are going to the future with antigen testing. And maybe what I'll do is I'll go back in the same order if that's okay. Sue, did you want to start?
Yeah, sure. And I made a comment in the what hasn't gone well, that one of the biggest challenges we've had is perfection being the enemy of the good. And so, and also mixed and sometimes misinformation about antigen testing. And the way we've looked at it at the panel is there's a testing and screening strategy that will work the best, and it's not either or. And yes, I think it goes without debate now that rapid antigen tests are not as quote unquote accurate as a lab-based PCR test. But I think it's also been established fairly significantly that if you can deploy rapid antigen tests in a workplace, in a congregate setting, in places like that, and do it frequently. And if you have a paradigm that says, if you have a positive result to a rapid test, you immediately go into PCR for confirmation. If you have a negative result, but you're in a high risk category, you go to PCR for confirmation. If you're low risk and you have a negative, you're coming back next week anyway, and we're going to test you again. And that combination of seeing how the rapid antigen tests and the lab-based PCR work together will be critical. And I think what happened in a number of our provinces is they started to talk about rapid tests are not as accurate as PCR, and kind of downgraded the public's willingness to get to embrace that. So that's one element. The second element is the lovely nasal pharyngeal swab, which doesn't, for if it's used, if that's what you've got and you're going to do that once every couple of weeks, that's not going to have a lot of willing customers. So now we've got nasal swabs, or we've even got what we call swish and spit. Different ways of deploying that test will make it more amenable to the audience. So that's we hit a roadblock in Canada because public health officials were talking about antigen tests in a less than supportive way. I think we have to turn that corner and see it part of a comprehensive testing strategy. Thank you.
Sharisa, how have you viewed the role of antigen testing for the state of Washington so far?
I think it's kind of been a mixed bag, and in part relying upon where people are being tested. So initially, when the antigen test came out, clearly we were concerned about the comparative lack of a reduction in sensitivity compared to PCR tests. And so initially, when we started to get the antigen tests, we were directing them, and our federal partners are directing them to long-term care facilities or skilled nursing facilities. And so in that setting, exactly what Sue is saying, you want to be sure you are cohorting people correctly, and you're putting people who might have infection with people who you know have infection. And so in that setting, we were pretty much doing PCR to confirm both positives and negatives, depending upon whether or not there was a case in the facility. Now we've adopted, if someone has an exposure or symptoms and they have a positive antigen test, that's a positive case. We have been more cautious with the negative antigen tests, depending on the context within which that person is getting tested. If they are negative early on or they have an exposure, we ask them to repeat that test in a bit. But I think the reality on the ground is probably for most providers who did not have access to testing early on, now that they have these rapid antigen tests and they're simple to administer and they can do it in their clinic and get the results right there, I think there's a lot of reliance on them, good or bad. And unfortunately in Washington, we can't tell how those rapid antigen tests are being used. We know we're tracking all the positives because that's a requirement for public health, but because so many tests, we distributed close to 2 million rapid antigen tests, and people who have never tested or had to report to public health are now testing, and we know we're not capturing all the negatives. So one of the challenges, we don't really know how they're being used. We know that facilities who typically are left out of public health responses, mental health, correctional facilities, as I mentioned, substance use disorder facilities are using those, but we don't have a good sense of the denominator. So we, because we don't have adequate access to testing nor equitable access to testing, have relied on those wherever we can get them for whatever population is willing to be tested.
Thanks, Emily. I'm sure you have a perspective on this, especially given the lower cost of antigen testing and its potential for greater accessibility, particularly in global environments. And I also know that you all have been extremely active around the home testing front. So maybe you could comment just a little bit about both, if that's okay, and then we'll go to audience questions.
Sure, yeah, and I think this piece that Sue highlighted has been, as you know, David, a longstanding interest of ours to really try to understand what are the pragmatic barriers of implementation. So, I think a rapid test that requires a PPE suited, trained healthcare worker really limits its ability to get out into these kind of community access points. And so the foundation's been quite proactive in trying to understand modalities of self-sampling and sort of stability, for specimen collection that happens outside of a clinical setting, exactly to address these questions of how can we get tests out of a kind of core hospital and into these more differentiated settings. But I think broadly, we do not see antigen tests as a competitive either or to a molecular. I think molecular is clearly the gold standard, but in many jurisdictions globally and obviously in Cascadia Corridor, there is some limit to the number of people who can access those tests. And so I think, as Teresa highlighted, the context is very important, and they need to be implemented with strong guidance and clarity around which use cases, which populations are they most appropriate for. And, I think the lessons we have learned from some of our global partners, as an example, there's a mid-size, sort of mid-income African country that 6 months in currently has the capacity to do 100 molecular tests a week. And the needs of that country are much greater than 100 tests can address. And so there's really no solution other than to augment that capacity with thoughtful implementation of something like an antigen test in the right population, in the right context. I think a great example of that, if people are interested in learning more, has been the way that India has rolled out antigen tests. They've really been on the front lines. They've actually quite a strong baseline molecular testing capability, but they have realized, particularly either for people who are sort of unable to access these central sites, perhaps they can't miss work, perhaps there's transit problems or other access issues, or for people who basically don't want to take large amounts of time out of their day, perhaps they're polysymptomatic or mildly ill, or they're young and they don't think, COVID is a big risk factor. There is clearly a subset of people who just are not going to those central clinical facilities. And so India has rolled out basically street-side kiosks with antigen testing. Now, they're almost certainly missing cases that they would pick up if those patients were in a clinical setting, but the reality is most of those participants were not going to the clinic. And so understanding those trade-offs and the sort of implementation details, I think is really key. I think on the home testing, this goes back to this question of how do you track these tests, who's using them, how do you connect them back into the healthcare system? This is a problem we've been grappling with for years in the context of malaria. You know, the world sends out hundreds of millions of rapid malaria tests each year, and they're generally only semi-quantitatively linked back into health data streams. And so we had pre-COVID active efforts to try to enable digital wraparound services that would help the administrators use those tests correctly, you know, in the right use case, to track some basic metadata about the participants, and then also provide support to the end user around, you know, simple timers, how long do you leave the buffer on, leveraging things like computer vision to help with reading the lines on the strip, which turns out most people have somewhat of a struggle with. And then most importantly, linking those back into core data streams, whether they're a clinical medical record of the patient or indeed for, you know, diseases of public health concern, back into public health data streams, and closing that loop between these community access tests and core central public health, I think really is a key question going forward.
Thank you. We've had a lot of questions in the chat about cross-border collaboration. I'm wondering if we can focus a little bit on that, which is, you know, where have we, what type of cross-border collaboration currently exists? Let's just focus the next panel will be dealing with vaccine R&D and antibody R&D, so that's a different topic, but really around this diagnostics area. How much can any of you tell us about, you know, to what degree Cascadia has been involved either in the development of testing and testing technologies? Clearly, Emily, the Gates Foundation has funded a lot of things, and you all have been at the forefront of that. I wonder if you could talk a little bit about the potential for more collaboration. Where do you see that going in the future? And I'll take any of you, whoever wants to go first.
Well, I'll make a couple of comments, David, both from a public policy perspective as well as the private sector. So I think, and I don't have any inside baseball information on this, but I think at least in Canada, for the last 11 months, there's been a lot of heads down in, I'd say, at a provincial level as well as a federal level, in a very much a crisis, sort of wartime reactive mode. And we certainly haven't heard a lot in Canada about cross-border discussions, although I will say that I think it's well known that our Premier, John Horgan, and your Governor, Inslee, are close colleagues. And so I think the potential to share information and experiences is there. I haven't seen it and I haven't heard it on our panel. That doesn't mean that it hasn't happened, but we've been looking more east-west than north-south from a public health perspective. Different in the private sector. And this is why I think it's so important for public health and private sector to work together. And I'll just give you a couple of tiny examples from the supercluster. One of the things that's happening as a consequence of COVID is a significant reduction in testing and therapies for other critical illnesses, let's call it cancer. We estimate in Canada maybe up to 100,000 treatments are being canceled or not taken, and we're going to see a significant problem there. We've got a project in Canada that's brought together a number of companies, large and small, some of which have head offices in Seattle, let's say, to develop blood-based cancer testing. And that's being deployed in the United States. In fact, it's being deployed in the United States faster than it's being deployed in Canada. And so there are opportunities like that, where if you can get a blood test that can, non-invasive testing rather than a biopsy, to evaluate the effectiveness of your therapy or where you're at, that can be a remarkable public health step. I'd say the other one that we've got, I could talk all day about the projects in the supercluster, but we'll save that for another conversation. But the other one I will talk about is what we call the COVID Cloud. So an international based platform for evaluating the evolution of the genome in the virus. And that's it because it's a cloud-based project or cloud-based platform that can take and is receiving input from not just Canada and the United States, but far beyond. And so those are just two examples, but I think the private sector has been far less fussed about borders than I think our public health officials have been. And that's not a criticism, that's just the reality that in the wartime, they've sort of really put their heads down. I think it's time to bring our heads up a little bit, maybe.
Thanks. Do you, Emily or Sharissa, did you want to add any comments to that or any different perspectives?
I would just say, I think, at least from what I'm aware of in Washington, most of the collaboration that we have done has been within the United States with the other Western states, talking about opportunities to share testing labs or different kinds of supports and ongoing supports about how are you handling this, how are you handling that in the absence of clear national guidance. So I would say I'm not aware of a lot of cross-border collaboration either, but I'll let Emily chime in.
Yeah, I mean, I think this is certainly true for Washington and BC, and then, I think really writ large internationally. The thing that has been an unexpected surprise about COVID is the fact that we've all had to go home and live on Zoom and on Teams. I think there has been a notable increase in participation from a more diverse collaborative set of entities. And so certainly around some of the core technology, data exchange, exchange of best practices. Sometimes those are being done in a more ad hoc basis where there are not formal, partnerships that are announced. But certainly we've been very pleased to see scientists from British Columbia talking to our local Seattle scientists or Californians, and then even reaching out to partners we have at Africa CDC, for example, to quickly share their best practices. We've had really just a lovely participation from scientists on both sides of the border, offering to provide, standard operating procedures or guidelines or, best tips and tricks to labs that are just standing things up in different jurisdictions. And, a lot of that happens behind the surfaces, but it's really been key to rapidly standing up capacity in places that don't usually have to deal with these sorts of problems.
Thank you. I think maybe one last question here and maybe I'm going to direct this one to you, Sue, which is really, there've been a lot of questions in the chat about how we can better leverage industry, particularly in this area of diagnostics. I think there'll be plenty of discussion about therapeutics and prevention or pharmaceuticals in just a bit. But where do you see opportunities here for us to be able to do more cross-leverage or cross-border leverage with industry in those collaboratives? Where do you see that coming from?
Well, it's huge. And I'd say one thing in Canada that, looking backwards, the benefit of 2020 hindsight, leveraging the research community, leveraging the private sector, it was a downside for us. We didn't do it. It's the opportunity of the future. And I think the history of the Cascadia Corridor, the commonality we have north-south in our culture, in our weather, in how we do business. North-south, we've proven that we can do things together. And I think it's a massive opportunity as we look to the future in terms of things like Emily has mentioned, the equity. We've had a huge issue with equity in our country where we've rolled mobile testing units into certain geographies, let's say bars and restaurants where the young people all come out and get tested. We roll them into high risk, low income congregate setting neighborhoods, and nobody comes. Why? Because they don't want to know that they've got a positive result, because then they have to stay home and they lose their income. And so getting the private sector to vend into helping develop policies around that. How can we support disadvantaged populations? How can we support employment settings? We just had a report come out yesterday of major employers, big employers across Canada who've run a pilot over the last several months or several weeks in terms of really intense testing in their workforces. let's get that going so that we can deploy public health resources to those that need it most, that don't have access to the benefits of a big employer. And let's share experience cross-border. This is a fantastic forum for doing that. The Cascadia Corridor, the work that Governor Gregoire and Greg have done is a fantastic vehicle that we can leverage looking forward.
Thank you so much. And with that, I think we're going to bring this panel to a close. Thank you all, for your great insights and thinking forward about where we might go toward the future in the collaboration between Washington State and British Columbia. This has been really illuminating and interesting. So we're going to go ahead and move forward to the next panel. And I'll be our next panel leader. I'll introduce right now. Thank you, Emily, Sue, and Sharisa very much. Our next panel will be focused on looking at R&D, particularly around vaccines and therapeutics. And I'm really pleased to introduce to you to Dr. Larry Corey, who's president and director emeritus of the Fred Hutchinson Cancer Institute in Seattle. Larry is really a internationally renowned expert in virology, immunology, vaccine development, and has a really longstanding history of involvement in running vaccine trial networks, and has been integrally involved in Operation Warp Speed and the development of COVID vaccine, and continues to carry a major role in that area. Larry has a great panel. I'll just briefly introduce them, and then I'll turn it over to Larry to moderate. We have, again, a superb group of experts in vaccine and therapeutics direction. Peter Cullis is the scientific director and CEO of Nanomedicine's Innovation Network and a professor at the Department of Biochemistry and Molecular Biology at UBC in Vancouver, and has been responsible for the advances in the development of nanomedicines that actually are being used currently in a number of the vaccines that have been deployed. Carl Hansen is the CEO of AbCellera Biologics and really works at the interface of engineering, biology, and computation. He's a co-founder of AbCellera, which is a company that actually has developed the world's first antibody therapy authorized to treat COVID-19. So is at the forefront right now in the therapeutics arena. And Lisa Jackson is a senior investigator at the Kaiser Permanente Health Research Institute here in Seattle. Lisa has had a longstanding collaboration with NIH and here in the U.S. And has been ran the first vaccine trial of the Moderna vaccine shortly after these vaccines were authorized for investigation. We're really pleased to have all of these panelists here. Lisa, I don't see your camera on. I don't know if it's just me. There you are. Perfect. Great. Larry, I'm going to turn it over to you. And thanks so much to all of you for joining today.
Well, thanks, David. We truly have a stellar panel when we look at the development through the clinical development of both vaccines and therapeutics. So I'm going to sort of ask, first Carl, then Peter, then Lisa, and then I'll go last to sort of give a brief overview of sort of how, what's the history of how they got involved. AbCellera really is the generator of the Lilly antibodies, and through their collaborations with the Vaccine Research Center at the NIH. So we have a lot of cross border practices here, and Peter, the nanoparticles that wrap up Pfizer are intimately involved with him. So maybe we'll start with Carl to really give us a little perspective about the history there and what's currently ongoing, and then we can go to some questions about the future.
Thanks very much, Larry. So maybe just as background, AbCellera is a technology company here in Vancouver. It's a technology company that works within the biotech and pharmaceutical industry, not to develop its own drugs, but rather to be a front-end discovery engine for firms that are working on the development of antibody-based therapies. So we have, over the past 8 years, starting from work that originated in my academic lab at UBC, been developing a platform to search and decode and understand natural immune systems in order to identify antibodies, which are molecules made by natural immune responses that are suitable for development as therapies. In part, over the past, I guess, 3 years now, we have been working on a project with the Department of Defense, so through the agency DARPA, that was specifically targeting putting in place rapid response capabilities for pandemics, specifically being able to quickly search through natural immune systems to find antibodies that could be repurposed either to prevent or to treat viral disease in the case of a pandemic. It was on the basis of that work that we had gotten our technology to the point of being extremely fast and effective at looking through natural immune responses to viral pathogens, and had formed some collaborations, which included a collaboration with the NIH, the Vaccine Research Center, with the labs of John Mascola and Barney Graham. On the heels of that work, in March of last year, when the first COVID case, or shortly after the first COVID case was reported in Washington, we mobilized that platform and we searched through the immune response of a patient that had recovered from COVID-19. And from that work, we're able to isolate a large panel of human monoclonal antibodies against the virus, the most potent of which is now in clinical development and has received emergency use authorization, called bamlanivimab. That antibody was developed through a collaboration that we formed very early in our response with Eli Lilly, and they have since moved that into multiple clinical trials, including the use of bamlanivimab by itself to treat those patients in early mild to moderate infection, where it has shown to be able to reduce the chance of going to the hospital by anywhere between 70 and 80%. It's also been used in prophylaxis in care home settings, where it had a similar effect in reducing infection and also in mortality. And most recently, the use of bamlanivimab in combination with another antibody for mild to moderate infection in patients who are at high risk of going to the hospital or experiencing morbidity or mortality, where again, it proved successful in reducing hospitalization by about 70-80% and was able to prevent all deaths. So we're quite excited and proud about that work that's been through that collaboration with the private sector, with Eli Lilly, and also with the public sector. And now really it's about manufacturing and making sure that antibodies actually get to patients. So I'd be happy to probably answer some questions on that front, but maybe at that I'll leave it.
Yeah, we'll come back to that. Manufacturing is a big issue for both vaccines and monoclonals. Peter, if you could tell us a little bit about nanoparticles, how you got into this and their importance with all things RNA.
Okay, thanks, Larry. What I'm going to describe, which is ends up being the Pfizer BioNTech vaccine, is really the result of 40 years of work. We started off in the 1980s, really trying to have two aims. One is to try and use nanoparticles of systems that are about 100 nanometers or less in diameter to deliver cancer drugs more specifically to where they're needed. Subsequent to that, we got about 3 drugs approved by the FDA to treat cancer and various complications thereof using this small molecule encapsulated in these lipid nanocarriers. And subsequent to that, we started to work on trying to deliver larger molecules. One of the reasons that we use small molecules is because they're the only things that can get inside cells. And so we have to have molecules that have molecular weight of 500 or so in order to be able to do that. Of course, when you're dealing with, say, DNA, RNA constructs, you're dealing with molecules that are 700,000-800,000 kilodaltons. They're much, much bigger. And so they require some interesting delivery approaches. We ended up working with a company in Boston called Alnylam to deliver their small interfering RNA. For those of you that don't know what siRNA is, it's just a way of silencing a gene in a cell, but you're using very natural processes to do that. Processes actually that the cell itself uses in order to regulate gene expression. That resulted in a drug that went into clinical trials and actually was approved in 2018. It gave some clinical validation to this approach. But in the meantime, the company that I co-founded called Acuitas then said, okay, well, will this approach work for even bigger molecules, such as messenger RNA? And it turned out that it did, but we were focused really on protein production in the liver. We were then contacted by an immunologist, Drew Weissman, University of Pennsylvania, who indicated he wanted to see whether or not this would make good vaccines for Zika virus and rabies and other applications. And that in turn led to us working with a company in Germany called BioNTech, which was working in turn with Pfizer to develop a flu vaccine. And so that work went extraordinarily well. But the upshot, of course, was last January, all attention switched to the COVID-19 pandemic, resulting in the production of a lipid nanoparticle formulation of the spike protein of the SARS-CoV-2 virus, which was very, very rapidly taken into clinical trials. I think we all know the results of that trial, which were quite spectacular. 95% efficacy or potency protection against disease in all cohorts, including the elderly. And the scale up that's going on here, if we want to talk about scale up, is again quite astronomical. I think Pfizer, BioNTech are now talking about 2 billion doses, and I'll bet you they're trying to beat that in terms of the number of doses that'll be coming out this year. Anyway, so a very exciting journey that we ended up on, but it does point out the sorts of serendipity that in a way it takes, you're working on one area, you get contacted by somebody who has a different interest, and then things take a completely different turn. To have a drug that goes from, as Carl was saying, goes from conception to approval in the space of less than a year is I think a mind-blowing event, particularly when it's a completely new form of drug. Which is the messenger RNA approach. I'll stop there. I just want to say one thing though, that is that this is really the advent of a myriad of possibilities therapeutically, simply because if you're using these types of drugs, really almost any disease becomes fair game. And so you're going to see a lot more drugs based on messenger RNA that's coding for a protein you might be missing, or else using sRNA to silence a protein that might be pathological, et cetera. But so the potential here is really quite spectacular.
All right, thank you. Very inspiring words. All right, Lisa, you were the first one to take this RNA and put it into people for COVID, and maybe tell a little bit about your story and where that's leading you now.
Okay. Well, we had that opportunity because we are one of 10 vaccine and treatment evaluation units. This is an NIH-sponsored network that's been continually funded actually since the 60s. And the aim of the network is to evaluate vaccines and therapeutics for infectious diseases of public health importance, and also, importantly, to have pandemic preparedness capabilities and to be able to react quickly to a pandemic, as we had a test in 2009 with the H1N1 pandemic. The VTUs in general were selected to perform the first trial of the first vaccine, the Moderna vaccine, because as you probably know, that vaccine was co-developed by Barney Graham and the Vaccine Research Center at NIH and Moderna. So it was originally designed to be a single site trial, and we were selected as that site at the end of January. And it's been pretty much a dead race every day since then. The vaccine was administered to the first participant on March 16th, which was 66 days after the viral genome had been posted online by Chinese scientists. So that was, I guess, the first unprecedented record broken. The trial was then expanded to include more sites as Seattle became an epicenter for COVID-19, and also to include not just younger adults, but also older adults. And that trial is still ongoing, although we've published 3 preliminary reports thus far of our interim findings. The VTUs then became part of the COVID prevention network that Larry co-directs, which is a network of networks. It brought in a lot of HIV-related networks and other NIH-sponsored networks and became a super network. And within that network, we've also been participating in the phase 3 Moderna trial and the phase 3 Janssen trial. Moderna has, of course, gone on to the EUA, and Janssen is probably preparing their FDA submission at this time.
Okay. Thank you. Thank you very much. I'll make mine brief. I prefer the role of the moderator here, but just to say, as Lisa has said, I have myself been the founder of the HIV Vaccine Trials Network about 20 years ago. And when I was at the Hutchinson Center as an investigator, and that has sort of grown into this very large collaborative network internationally on HIV vaccines. It's not just a clinical trials network. It has these laboratories that were established to validate the assays between different platforms of vaccines, as well as some of the world's finest biostatisticians in vaccine design and the computational biology of immunology. And so when COVID came around, I've worked closely with fellow we all know. Some people call him ASF. I call him Tony, Anthony S. Fauci, and who's been a friend and collaborator. And we put all these networks together to take government, academia, and industry and put it together to see if we could do this thing of trying to implement and test these vaccines as quickly as we can. And remarkably, we had the result of the same strand of RNA wrapped in a slightly different lipid nanoparticle, giving us incredibly similar results of 95% efficacy against the disease and pretty close to 100% efficacy of severe disease and hospitalization. We thought we were sort of sitting pretty for about 3 weeks. Then the virus sort of threw us a gambit in the last little while. So between the 3 weeks of time and December to January, early January, thought we were sort of doing okay. But now we find that the virus's gambit, like all RNA viruses, is that they have the ability under immunological pressure to vary and mutate. And these mutations have been twofold. One of them is to increase the transmissibility and the ability to attach to the receptor in the nose and have higher titer in the nose and higher transmissibility. And we see that in first in the, we actually saw it back in June in one mutation, but in a more significant mutation in the UK variant. And then we see that same mutation be now combined with a series of mutations that interfere with neutralizing antibodies. And come back to Carl's thought about sort of strategies to mitigate against that. That the combination of both in the viruses is happening in the South Africa strain. This week we learned that that does reduce the efficacy of mainly antibody-mediated vaccines. It may not reduce the efficacy of T-cell mediated vaccines. We saw very good protection against South Africa strain, as good as the United States in severe disease with the J&J vaccine that doesn't give very good antibody levels, but gives more CD8 T-cell responses. So we do have things in our armamentarium here, but the virus also has its strategies, which I guess maybe indicates job security, but there's anxiety here among the populace about how do we control the variants and how we as science sort of keep together with that. So I'm going to pitch this first to Carl to sort of say, okay, Lily is going to have a little bit of a problem with the South Africa variant, and what are the thoughts about that, and where are you taking your company and what opportunities does this give AbCellera and its technologies?
Thanks, Larry. So great questions and timely questions. Maybe the first thing to underscore is that today we have one monoclonal antibody that has emergency use authorization, bamlanivimab, that is out there. That is an exceptionally potent antibody. It's one that responds to the vast majority of strains, including the UK strain, without any compromising of the potency of that antibody. Antibodies, by the way, should be thought of as synthetic immunity. It's a way to give a patient quickly the protection that they would have had if they had responded appropriately to a vaccine for a virus. An antibody, however, whether it's one or two, is going to recognize only certain points or epitopes on the virus, and so is inherently vulnerable to mutations that change the surface of the virus and make the antibody not bind. One of the mutations, or a series of mutations that have come up recently associated with the South African variant, do reduce, in fact, wipe out the potency of bamlanivimab in neutralizing that virus. So as of today, that variant is a very small fraction of what is actually out there. It's much less than 1% of all the strains, but it is one that you need to watch in case it were to become more prevalent and spread. Our view on this is that in the same way that we were able to respond quickly in the first crisis and bring an antibody from screen to the clinic in 3 months, we have the technology platform to respond again. And we may find that we are doing that on a regular basis moving forward as we start to respond to where the virus goes under immune pressure. Dave Ricks, in a call recently, CEO of Lilly, indicated that we do have one of our antibodies already that's moving into development that is potent against the South African strain. And so we have a solution on deck already. And that work came from not taking the foot off the gas after the first one was found. So we had continued to do screening of human patient samples and have generated now thousands of human antibodies against COVID-19. And so based on that large diversity of antibodies, we had a full hopper and we were ready to bring one forward. I do think that it is worth continuing that effort. And as the virus moves, a considerable way in terms of evolution away from the first strain that we had, we should probably look at those responses and cast a wider net to make sure that we are ready for the next one. And of course, we're working on that now.
Okay, great. Peter, do you have any collaborations in your nanoparticle sort of milieu as it relates to working in the Pacific corridors with companies or institutions cross-border, or?
Not really. I mean, there's something I'd really like to get in place. There's such a wealth of experience and depth, particularly in the Seattle area, and so this is one of the reasons why I think this whole initiative is so important, that we establish. We do have various areas of expertise in both jurisdictions. They can very easily play off each other to get to the next level, and I think it's a very important thing for us to do. I just wanted to go back to what you were asking Carl about in terms of the mutations or the new variants that are appearing of COVID-19. Again, from a vaccine point of view, it appears that the mRNA vaccines are extraordinarily potent and able in many ways to be relatively potent against many different strains. I mean, this is coming out of work actually for influenza, where it's some of the work that's to generate immune reactions to one variety of flu these vaccines are also effective, at least in animal models, non-human primates, etc., for other strains of influenza. And so you're kind of looking at the potential for a universal flu vaccine. Whether that's going to be the case with COVID-19 remains to be seen. Of course, the other thing is that, as Carl was saying, for the antibodies, new vaccines can be generated very, very quickly once you know what the sequence of the genome of the virus that you're looking for. And that's evidenced, of course, by the fact as soon as the sequence of SARS-CoV-2 was elucidated, then a month later you have a vaccine. It's just a matter of making the mRNA that codes for, in that case, the spike protein. So there's twofold things going on here as far as the mRNA vaccines are concerned. One is that these vaccines are inherently pretty robust, looking at different strains of the same virus. And the second one is that if necessary, they can be adjusted pretty quickly to convey protection against a new variant.
Right. Lisa, you want to comment on that as to what you're hearing about strategies about RNA as it relates to the variant?
Well, I anticipate that we'll be pursuing a strategy of evaluating, vaccines tailored to the variant and/or also to, the original Wuhan strain, which is what the Moderna vaccine was based on, of course. I'm sure that we're not done with this, so we'll see what variants tend to emerge as we go forward. But it is, as you said, Larry, it's a significant new challenge that we've recently recognized.
I think that the data from the Novavax trial, which is not RNA vaccine, it's a protein vaccine, but makes antibodies that are significantly similar. About the titers are similar. No one knows what we call the repertoire, what the repertoire is between RNA versus a protein vaccine. But and certainly some of the T cell responses are different. But you saw a reduction from 90% to 50%, 90% in the UK and 50% against South Africa. So I suspect that we will be using RNA technology to create a variant, or maybe be able to use sort of bivalent or even develop a synthetic universal SARS-CoV-2 vaccine that will prime and do what Peter is talking about, which is sort of initial dose that could theoretically cover many strains that is happening. I want to ask the question about manufacturing, because I'm not sure our region spends that time in manufacturing, and maybe company strategy or thought about this, both for Carl and Peter, about sort of what the role the region is in manufacturing. Have we really had much of a role? Should we have a role? Should that investment be a public-private partnership to improve manufacturing capabilities of biologics? Because, I don't see antibodies and vaccines going away. We see I don't see nationalism going away, and vaccine nationalism going away. So what are your sort of personal thoughts about this issue of more downstream emphasis in our life sciences corridor? Would that help your companies? Would that lead to new opportunities? What other CEOs who you talk to say about this?
I could take a first crack at that. Certainly for antibody therapies, right now, we absolutely should be in a case where we are supply limited. So antibody therapies are given to patients at highest risk when they're already sick. In the US, it's estimated there may be up to 45,000 cases that would fit that category per day. To date, there have been, last I saw, somewhere approaching 750,000 doses that have been distributed across the United States. And so you can do the math and realize that there are many more people that are getting sick and that would benefit from antibody therapies than we have antibody therapies being delivered. The hard limit on that currently is manufacturing, although there is currently also some work to be done in logistics and education and uptake in the centers that get the therapies. In Canada, if you talk about regions, in Canada, we do not have to date any manufacturing capability for biologics, for antibodies. And that is something that I think every country is looking at now and realizing that there is a good reason to have that, both for economic growth and opportunities locally, as well as for preparedness if a pandemic should come again. And we are seeing the impact of that right now in vaccines and antibodies. AbCellera is actually currently working on that problem here in Vancouver. So in March, we had a financing from the federal government that was largely intended, the majority of which is to build up CMC and GMP manufacturing here in Canada, in part for pandemic preparedness, and also because we have a business that is focused on generating antibody-based therapies. And to be able to add to the back of that, the ability to manufacture here in Canada means that we can move those therapies more quickly from concept to clinical testing, which is good for the partners that we work with around the world, as well as good for patients in the industry in general. So we are investing heavily in that. We're creating jobs here in Vancouver. We expect that it'll be well north of 250 or 300 jobs associated with that in the long run. But that is a project that will take anywhere between 2.5 and 3 years to complete. So it's something that you don't do when you realize that you need it. You need to build capacity and have it ready for cases like COVID-19 when it's important to move quickly and to be in control of your supply chain to the extent that you can.
Okay. And Peter, the supply chain for lipid nanoparticles, are any of them made in our region? And is there a issue with the supply as we need to make billions of doses and now we have to make a variant vaccine on top of that? Are we going to be limited by the absolute supply of nanoparticles?
Oh yeah, I think there's no doubt of that. From what I hear, some of the issues that are being faced is, say, Pfizer, BioNTech, and Moderna, for that matter, are, as they scale up, the supplies of everything from the lipids to the mRNA becomes an issue. The mRNA, surprisingly, is probably not as much of an issue in terms of being a limiting element, and that's really due to the extremely small amounts of the mRNA that are used per dose. I mean, it's 30 micrograms per dose of mRNA for the Pfizer vaccine, about 100 for the Moderna. So while I thought that was going to be a limiting factor, that hasn't turned out to be the case, at least from what I hear. But certainly the lipid components and some of the manufacturing elements are a concern, and there's a lot of build-up going on there, both in the U.S. and elsewhere, to make sure that the requisite reagents, the requisite components are made in the appropriate manner. Just with regard to manufacturing here in Canada, I think that there's a general awareness. We got caught with our pants down, really, in terms of not having the requisite capacity by manufacturing capacity to produce vaccines at home, and so we're dependent on vaccines that are manufactured elsewhere. So I do think you're going to see a pandemic response capability established in Canada to produce vaccines, as needed. That will probably be a public-private partnership of some sort. But all I can say right now is that we're actively engaged in getting that in place. The thing is, this would not be in any way a white elephant, simply because, as I mentioned, the need for this kind of facility for other mRNA products, etc., will certainly keep it extraordinarily busy in times when there wasn't a global pandemic going on. But when you hit the global pandemic, you better have that resource. It's otherwise you really do have a tremendous problem, as we've seen. The damage worldwide is unbelievable, and a lot of this could have been, or certainly next time around, we have to be way better prepared. There's no doubt about that.
I'm going to shift to my own opinion and ask my own question to this for the United States, and that I honestly have written letters both to David Kessler from the operation and Tony, sort of asking that the Biden administration consider using the National Defense Act to both repurpose and subsidize new factories for manufacturing vaccines. I think that this virus is going to be with us. These variants are there, working in biologics, whether it's monoclonal antibodies or vaccines. The factories can now be somewhat utilized in making biologics. There's an incredible shortage of manufacturing of these technologies, and why we in North America should be outsourcing this to other countries is unclear to me. And I think that these pandemics illustrate the importance of that and the potential for jobs creation. And I think this is an area that we need to have public-private partnerships to jumpstart that and use the technology that is available in industry to run it, but to subsidize the construction of this is enormous investment, but an incredible long-term investment. So personally.
Larry, I just wanted to say that I think I would agree with that completely, and also underscore that the countries that have been best prepared and probably not prepared enough are those that do have a vibrant sector in biotech and pharmaceutical industries. And so the US has obviously been driving a lot of this. I think that's a good signal, to other jurisdictions, including Canada, on the importance of this sector, which is a great place for investment and employment, but also one that's critically important to defense and defense, characterized broadly, including that against pandemics. And so I think this is a wake-up call for other jurisdictions outside the U.S. and the U.S. as well, to double down on that. And I do agree that this happens best through public-private partnerships. It's hard to sustain these things on the public sector, but sometimes you do need a little bit of a boost to get it going.
Yeah, well, I agree. Well, there's some downstream questions, and Lisa, I'm going to give you a hard one, which is the issue of opening up the border and vaccine passports, vaccination status, your sort of thoughts about should we give sort of special dispensation about travel to people who are vaccinated, and what do people think about it? What do you think about it as a physician epidemiologist and looking at our epidemic both in BC and the United and in the state of Washington?
Well, that is a hard one. It's challenging because we don't know that people can't still acquire the virus, in the upper respiratory tract and transmit it. I would suspect that there's at least some diminishment of that, if not sterilizing. But until that has better information, you may not be really helping things by allowing people to overcome barriers to travel based on their vaccination status. So I think that that's an important step. Then there's obviously social issues with, hardly anyone has been able to get the vaccine so far, and so you're giving preference to the lucky few or those who are targeted in priority groups and so forth and so on. But, maybe after vaccination is more widespread, that might be something to consider.
Right. Well, maybe your thoughts of adding antigen testing to that. If you were got a rapid antigen test, I think you're absolutely right. We don't know whether you can still acquire it and still transmit it. We're still talking about, using masks. We haven't really looked at this issue of transmissibility and acquisition. The vaccines at the moment are to prevent disease, and if you combine that with a rapid antigen test at the border, is that something that your patients and you would feel more comfortable with in travel?
Yeah, I think every step adds security. Of course, that's just a one-time point assessment. But then when they would enter the next area, they would be more equivalent to people who are already in that area and subject to the same transmission and exposure to the same strains. So it's a question of how much intensity is worth it. The example of what the NFL has done with very intensive strategies of testing and real-time monitoring and genomic sequencing of all that to determine transmission has been successful. So if you have enough resources, you can do it, but there's going to be that tension of how much what's the benefit, what's the magnitude of the scope of whatever needs to be done to ensure that we meet the goals that we have for keeping transmission tamp down as much as possible.
Great. And maybe the last question, we have about 4 or 5 minutes, is what are the lessons learned? Actually, can we keep this pace of accelerated development? I mean, I'm not sure we'll always have 95% in 11 months. And from the time you isolate an antibody to actually get it was also 11 months, maybe even less, 10 months, sort of amazing. Can this pace be sustained? And what would be sort of the low-hanging fruit that you would sort of say, a disease that you've been thinking about or working about or working on that you think, this kind of pace can achieve that kind of success, this kind of success?
The first thing I'd say to that is that in both the case of the antibody therapies, so from beginning a program to first in human testing in 3 months, and then approval within 10 months of starting, but also the vaccine similarly, it's a tremendous example of investments in technologies that have helped to accelerate the path from going from an idea to a clinical ready product. So that is one of the first things I would say. And I don't believe that we are anywhere near the top of that curve. So there's a lot still to be done in technology, and it's hard even to anticipate where we're going to go there. In addition to that, this is a proof point that the process of the regulatory path and the development and the way that you work between the private sector and the public sector can be much more efficient than it traditionally has been. And I don't think that we're going to be in a scenario where we are going from initiation to human testing in 3 months outside of a pandemic anytime soon. But we now have evidence that that could happen, at least in some diseases. So to think that we could figure out a way to reduce the median times of drug development, which are currently approximately a decade, depending on which statistic you look at, and bring those back to 5 years, 4 years, 3 years. The tremendous amount of value that you could generate, for the industry, for investors, and most important for patients who are waiting for these therapies is clearly there. And I'm hopeful that this will be a bit of a reset, that we've raised the bar and people will no longer be satisfied with these long timelines for development. So that is what I would say there. The other side of which indication would be most easily addressed to move that quickly. I think that's a pretty complicated question. I do think that we're seeing a very important role for monoclonal antibodies in infectious disease, which has happened in the past, but I think has been underinvested in. And given the way that I hope the regulatory environment is going and what is needed to get these forward, we might be seeing that pick up steam move from here.
Okay, great. Peter?
Yes, just to echo what Carl said, it's early stages. It's quite remarkable that in these early stages we have vaccines, antibodies, etc., that are as effective as they are. But they're very definitely going to see these vaccines and so on, really quite dramatically improved as time goes on, and they're very rapidly adaptable. So, but one of the things.
Press 2. For Star Direct Satellite, press 3.
There's some background noise here. One of the things that
if you are currently a Shaw Mobile customer and would like to inquire about the service,
emphasized is that the turnaround time, as we saw for a vaccine, of say a month or two, what that extends to for messenger RNA-based therapeutics, that extends to pretty much all of them. That once you identify that somebody, say a child just born, has some genetic defects, isn't making a protein that causes their blood to clot, whatever the problem is, you can devise a mRNA to make that protein, manufacture that into an appropriate lipid nanoparticle, and have it ready in a time on the order of a couple of months. And so here you're starting to run into regulatory issues, as Carl said, our previous way of doing things. But I think we're going to have to bring things down not just to 5 years or less, but even less than that, because the pressure is going to be there. When parents have really sick children, and there is clearly a solution there. At the moment, they're trying hard with virus-based approaches, which are intrinsically way more difficult. But as these much more straightforward approaches come into play, we're going to see, particularly in the areas of rare disease, enormous pressures to dramatically shorten that timeline. And so I think that's going to be a really interesting approach. And in the end, most diseases are rare diseases. All cancers are rare diseases when you get to a certain point. Anyway, so it's a very exciting time, but it's pretty revolutionary in terms of the implications for standard ways of doing things.
Right. Well, I think because of time, I'm going to turn this back to Greg to wrap us up. But I guess I'm going to sort of bring it back to, I think what this pandemic has said in warp speed and the antibody and says is sort of an axiom that I think that all our mothers taught us. And when there's a will, there's a way. That actually has occurred with this when you really put us all together. And yes, funding, having enough funds to be creative and to pull out all stops. But if you want to solve something, goodwill, hard work, and definitely money can solve things. And so I think that's my main lesson learned. And I'll turn it back to Greg.
Well, thanks so much, Dr. Corey. And this is just a fascinating conversation. My first year science professors would be thrilled I'm even using some of the terminology I'm about to, but I come by it a bit honestly, as does Governor Gregoire. When we first met 5 or 6 years ago, Chris was the chair of Fred Hutch, and I was the chair of the BC Cancer Foundation, and just world-class centers for doing amazing work in precision medicine specifically. And we could have had this conversation in a myriad of different pieces of research and work that Dr. Corey has his fingerprints all over, and many on this call do. The discussion in many ways is feels a little bit like a fireside chat 10 years from now about what did you do in 2020 to make a difference on COVID, and we're living it in real time, as we heard. I've got the task of just a couple of specific kind of takeaways from both the panels, and it's just exhaustive, but I wanted to touch on a few commonalities and a few specifics. One is, it was quite clear between both panels to me that, working at common purpose collaboratively at speed ends up with great results, both between academia, the public sector, and the private sector when they're all working in synchronicity. And we get stuck and frustrated and sand in the gears when our systems and processes don't allow for that collaboration at speed. And the second is that, there's some learnings out of this around how we map and consolidate materials, supplies, manufacturing, and the tools necessary to respond to not just COVID, but also the challenges we're going to have in the future from a public health perspective. The other side is let entrepreneurial action flourish. And I think, to echo some of the first panel's commentary, don't let perfection be the enemy of the good. And in that context, how we trial, evolve, and continually learn and apply that learning to public health is really important, and some molds have been broken, certainly during COVID. And the reality around the exposure, and we heard that in a bunch of different ways around access, but the economic and public health inequalities that have been exposed through COVID itself, and how we think holistically around the role that public health has from both inclusiveness, diversity, and equality perspective. And a couple of other quick items around testing and tracking and tracing solutions, around just how we work in multidisciplinary fields, but also cross-jurisdictionally. And so lessons learned on public policy around how we coordinate in anticipation of the next virus or public health challenge we're going to have, which includes that cross-border collaboration. I'll speak to a bit of that in a moment. Carl spoke a little bit about the work that they did accessing data out of Washington State that really helped them accelerate their mRNA work that ultimately created both therapeutic product that they have with high efficacy, but also, I'm sure, the work with Lilly. And Sue talked a little bit about the blood cancer based testing that's being done between US and Canadian firms up and down the corridor for cancers which are non-invasive and more rapid and expansive, again, getting to access, but also getting to accuracy. And then the other side is that the strengths of the researchers, the institutions, the private sector, our data, our genomic sequencing capacity, and our collaboration is really powerful. I want to just specifically talk about the last panel. So much great information there from the panelists in terms of what's actually happening and how people are continuing to evolve their thinking around both mutations and also the applications of mRNA and some of the breakthrough technologies, setting new expectations from moving from a decade of drug approval to less than 5 or 4 years moving forward, how we create new systems to be able to do that. I'll use an off-term definition, which is probably a little bit inappropriate, but I grew up in agricultural communities, but using a veterinarian term of off-label, how do we actually use mRNA and other applications for drugs that might be specific to one purpose, but actually have efficacy in others? And then we talked a little bit about building out the infrastructure to rapidly undertake both access for the public, but also manufacturing and surety of supply chains going forward. So the manufacturing capacity of not just the vaccines themselves, but also the inputs into those vaccines, like lipids and others, are going to be crucial. And as I said earlier, one of the questions in the panel was, what is Cascadia doing around this? And I think the bigger question is, what is the potential that we could have? And so, for example, in the middle of the pandemic, outside of COVID, there was an announcement made around building out the Cascadia Data Alliance, which is something that started 4 years ago in a collaboration between Fred Hutch, University of Washington, UBC, Cancer Agency, and others, really trying to look at how we leverage data, how we leverage expertise, and how we build products that address oncology and precision medicine in oncology going forward. And there's lots of work, I know, as HIV and Hep C and others that are taking place. But as Peter Cullis talked about, we now have 8 people on these panels that are in the middle of saving lives and the global pandemic within 200 miles of one another. And the potential for these kinds of platforms, and Chris and I have seen it relentlessly, of collaboration at speed and getting to know each other, understanding and the common use of data, and the ability to collaborate, as Dr. Corey has talked about, and bringing people together and providing that leadership is just powerful. And I think we've got that power inherent in us in the Pacific Northwest, as we heard today. And so with that, I just want to thank just an extraordinary panelist, our co-chairs, for putting this together, David and Lesley, and specifically Emily and Charissa, Sue, David, Carl, Peter, Lisa, and Dr. Corey for just an outstanding presentation and event today. Thanks so much. And now over to my friend Chris Gregoire to wrap things up.
Thanks, Greg, and thanks to everyone for joining today. We very much appreciate it. I want to add to the list of thanks, a big thanks to Cheryl at BCBC, Kaylin at Challenge Seattle, who have worked together to help make sure the infrastructure was there to pull off an amazing program with really, really wonderful experts. I've learned 2 lessons today for Greg and I, 2 takeaways. One, that as much collaboration as we think we are doing, there's a whole lot more that we can do, and we are clearly better together. So we want to keep working on that. If you've got ideas, suggestions, would you please get them to us? And the second one is, I think with regard to the challenges that we're all facing, one of the things that needs to be emphasized is public-private partnerships. And that is both across the border and within our respective jurisdictions. We've seen it alive and well and here in our state. I know you have in British Columbia. And so if we can be part of that culture in Cascadia, in our public-private partnership, then I think we will all better serve the citizens of both Washington State, Oregon, and British Columbia. So with that, this has been recorded. It will be available on our website, so you can share with colleagues and others that you would like to. Again, if you've got other ideas or suggestions, could you please get them to us? Thanks so much for joining today. Be safe, be well.